I'll just wait for a few more people to join before we get started. Hi Liam. Hi Catherine. Sorry, a couple of minutes late because someone is locked in the clinic. So we've been trying to get them out, but hopefully it won't be long until they're released. Hi Ainsley. Oh, hi Stacey. Right, let's get started. There's a few of you on here, and if not, people can watch the replay as well. If you someone can comment saying that you can hear me okay. Hopefully you can. I'm at home, so it's quite quiet. And then we'll get started. Great, so today is all about the knee joint. So we're going to talk a little bit about the anatomy, a bit about what causes injuries to the knee joint, what we can do if we have an injury and what we can do to prevent it. And a few of you have already sent in questions beforehand, so I'll be making sure to answer them as well. So knee joint, we have two joints actually that sit at the knee. We've got our tibiofemoral joints, that's our shin bone, and our thigh bone, and they make a hinge joint. So a bit like a door hinge, just goes one way. With our knee though, we do get a little bit of internal and external rotation as well, which all that allows us to do is when we're standing up and we've kind of, we're not bending our knees at all, our knees are completely straight. They have a slight lock on them so that we can then lock and unlock the knee. This does make it slightly more complicated as a joint compared to, for example, your elbow, which is also a hinge joint, but it's still easy to work with. Our other joint that we have there is our patellofemoral joints. That is patella, so our kneecap, and our femur as well, so our thigh bone. And that is a synovial joint, which is also a sesamoid joint. So without getting into too much detail, sesamoid joint just means that you've got a bone that sits in the middle of a tendon to make a joint, and that's what we have at our knee. And our patella, so our kneecap, is our biggest sesamoid joint in the body, or sesamoid bone in the body. Going on to the ligaments, we've got our ACL, so you've probably heard of this before, anterior cruciate ligament. What this does, and if you looked at my Instagram story the other day, I did a little quiz on it. It stops your tibia, so your shin bone, coming in front of your femur. It stops this from happening. Imagine if you were to kick a ball, you don't want your shin to keep on going, you want your shin to stop. That's one of the things that it helps with. Our PCL is our posterior cruciate ligament. That just does the opposite to the ACL. So it stops our femur going behind the tibia as well. So they both work together in conjunction to make sure we're not having any more movement than we should do, front or back. And then we've got our LCL and our MCL. So these are our collateral ligaments that sit on the inside and the outside of our knee joint. And what they're doing is stopping our knee from coming too close to the body or too far away from the body. Our MCL is more commonly injured because it's more likely that you're going to get a blow on the outside of your leg than on the inside of your leg, which is going to cause a potential injury. And also with your MCL, your ACL and your meniscus, which we'll talk about in a second, that can sometimes be an injury that you get all in one go as well if it's a bit more of a traumatic injury. So we've then got cartilage that covers the ends of the bones, and that's called hyaline cartilage. That's just so we can get everything rolling on each other pretty much rather than grinding on each other, because that wouldn't be very good at all. That would be quite painful. And then we have our meniscus, which you've probably heard of as well. Meniscus is sort of a little bit of cartilage that sits in between our tibia and our femur like this. And it's there for shock absorption, and it's also there for a bit of cushioning and support as well. So if we start to wear this down, that's when we end up with things like osteoarthritis. We can also get tears of the meniscus as well that can be really painful. They can kind of flap over as well, and that can cause them to lock and to catch. So that can be pretty sore as well. And then looking at the musculature, we've got lots of muscles that cross the knee. We've got our adductors of our hips, so they're the muscles that sit on the inside of the thigh. Front of the thigh, we've got our quads. Back of the thigh, we've got our hamstrings. Then we've got our calves as well that also cross behind our knee too. On top of this, our glutes, although they're not connected to our knee in any way, help control the movement at our knee. So if we haven't got great glutes for whatever reason, potentially that is going to have an impact on our knee too. So that's just something else to think about when we're thinking of the knee. So when we're looking at what causes injury, for knees, we can pretty much separate it into two categories. We've got traumatic and atraumatic. Our traumatic injuries are going to be things like ACL ruptures, MCL ruptures, medial meniscus, anything that's kind of been caused by contact, a contact sport like rugby, and that's hurt the knee. That's a traumatic injury. Car accidents as well. The thing is with traumatic injuries, so it can be, like I mentioned, rugby, someone's given you a big whack to the outside of your knee's come in, your foot's gone out, and potentially you've ended up with an ACL rupture, an MCL, and a medial meniscus tear as well. But you don't need the contact. So it can just be that you put your foot down, foot's kind of skidded one way, you've gone the other, or maybe you've jumped from a landing, you've just lost your leg underneath you. That would still be traumatic, but it's not a contact related injury, but it's obviously still caused a lot of trauma in the area. Our other type of injury is atraumatic. So that means it's not a traumatic mechanism, it's happened over time. And this is something that I really commonly see with ones that have built up. So someone will come to me, a patient will come to me and say, oh Joni, I've had a bit of knee pain. It started like 1, 2 out of 10, it wasn't too bad. But I left it for 3 months and now it's kind of a 6, 7 out of 10. I can't exercise, I can't go down the stairs without pain, I can't do this, I can't do that. And often this is going to be more technique based. This might be they've just started going to the gym and they're now squatting, and there's something going on with their technique that has caused basically an overuse injury. It could be from running, similar thing, they've just recently picked up running, or maybe they're now running on the road and they were previously running on grass, they've changed their shoes. It can be things as small as that cause differences that then cause pain at the knee. And it's not something that is suddenly painful, it does normally happen over time and is a build-up. And for those ones, particularly that are a build-up, that's when it's really important for us as physios to say, I'm not just going to look at your knee, I need to look at your foot, I need to look at your ankle, and I need to look at your hip. Because if I'm not looking at those, then I'm never going to work out what the cause is. Very often in knee injuries that aren't traumatic, there is a cause outside of the knee that we need to be really mindful of as therapists to work out what's caused it. And that can be if your foot, for example, is flat-footed and it comes in slightly, that can cause your knee to then come in slightly. That's going to put more pressure on the inside of the knee, and that's going to cause you problems. It could be your glute minimus and medius, which are the sort of glute muscles that kind of sit top sides, that they're a little bit weak, and they really help control our knee and our foot and our ankle, and they're there for stability. So if we don't have particularly strong glute min and med, that could be a reason why as well. So as a physio, I'm not necessarily going to say, okay, I want to see the movement at all of these joints, I want to see the strength at all of these joints. I'm probably just going to say to you, can you do a squat? And I'll just watch you. Can you do a split squat? Can you do a single leg squat? There are a few different things that I'll look at, because just from looking at that, I'm going to know what's weak, what's strong, what do we maybe need to do just a little bit of work on. And that's something we can look at. We do also have kind of referred pain at the knee. So this is actually quite common with people that have hip pathologies, particularly like hip arthritis, for example, often will feel that into the knee. And that's referred pain. We can get referred pain from neurological issues as well. If you're having some kind of nerve pain, that could potentially cross the knee too. And if you're looking at sort of your osteoarthritis and your arthritic knees, again, that's something that just builds up over time. Arthritis is a natural aging process, unfortunately. It's just that some people are symptomatic with it and they feel pain and other people aren't. So that's the main difference for them. So when we're looking at knee injuries, we want to see, can we prevent them from happening? Prevention is better than cure, and that's what I'm always saying to my patients. You know, they come and say, most of the time people say, you know what, I wish I'd come sooner. And I'm like, yeah, well, if you come soon, if you come when you first notice this pain, we could have adjusted your technique, we could have done this, this and this, and you would have been done quicker. But you've come 3-4 months down the line and now it's going to take us a little bit longer, but we'll still get there. So when it comes to preventing injuries, the long and short of it is that yes, we can prevent them. And that's things like leg strengthening, so that's strengthening our quadriceps, doing things like squats, lunges, doing hip thrusts, practicing jumping and landing. That's really important for sports such as netball, rugby, football, basketball, where you're doing a lot of jumping and landing, and we do see a higher injury rate in those that play those kind of sports at the knee, and that's because they just require so much force to go through. So leg strengthening is really important, and I did ask people if they had questions beforehand, and someone did ask me a question about leg strengthening, what the best exercises to do are for knee strengthening specifically, and there isn't any specific exercises that are going to be good for everyone. It's going to be very much personal. So if your hamstrings, for example, are quite weak, then that could open you up to an increased risk of ACL injuries, because our hamstrings act a little bit like an ACL in that they pull the tibia back and they don't allow the tibia to go in front of the femur. So it's things like that that we need to look at on an individual basis. For a lot of people, if you play a sport like netball, you're probably going to be a female. And a lot of us are quad dominant, which means that we've got larger quadriceps. And the reason for that is our hips are wider, and therefore our Q angle, which is just the angle looking at our hips to our knees, is going to be wider than that of a male. And often then we put on more muscle in the quadriceps than we do in the hamstrings at the back of the thighs as a result. So that's when I look at doing exercises like RDLs, like hip thrusts and single leg things. So yeah, we can prevent them. The things that are harder to prevent are our traumatic injuries. If it's a traumatic injury as a result of contact or a car accident, something like that, we have less of a chance of preventing it, unfortunately. You can't help it if a 110 kilo rugby player is going to run at your knee. It's just going to happen. But what we can do is the traumatic injuries, like your ACL injuries that happen without anyone else around you, and you've probably seen it when you've been watching football or rugby maybe, a player sort of loses their foot slightly, probably slips out to the side and they're on the floor, they're screaming, holding their knee. They're the ones that we can prevent. No one's around you, no one made your foot move, we can prevent that. And there are things out there, like FIFA have done a program that's looking at preventing ACL injuries, you can access online as well. So things like that are really important, because that's going to then in the long run help prevent those traumatic injuries that do happen. And if you've had a traumatic injury that's not contact based, the chances are you're predisposed to that injury, therefore the other side potentially might then get the same injury. And I've worked in rugby clubs when we've sent a player back out after an ACL rupture on their left side, and then they go first game back and they do their right side. So it's something that you really need to think about, as well as, okay, how do we prevent this from happening on the other side too? So that's something that you need to look at. And if you're unsure, if you feel like maybe your technique isn't right on something, like when you're running, when you're jumping, when you're playing sport, that's when physios come in, because you can come to us and say, actually, I really want someone to just take a look at me doing this. What do you see? And we can be like, okay, yeah, we'll have a look. Okay, so straight away we can see that this is weak, this is tight, this is strong, this needs some work, whatever it is, and we can give you exercises to help with that. We're not just here for when you get injured, we're here to help you prevent getting injured too. And that's one of the really key ways that we can help you. So if you do have an injury to your knee, what can you do is our next section. Well, it's kind of hard to say, because it very much depends obviously on what it is. But we'll always look at similar things. One, have you got any swelling or bruising? That's going to be the first thing that we want to get down. So at our knee joint, we can have swelling inside the knee joint itself. We can have it outside the knee joint. If it's inside the knee joint, there's a test that we can do called a sweep test that we can have a look for that. I don't let my patients really wait there unless they have to. So they're allowed to walk around at home. They can't go for actual walks. All of the exercises they do are just focusing on getting quad activation, getting their glutes activated, their hamstrings activated, but what we would call open kinetic chain exercises. So this is where your foot isn't in contact with anything. Essentially, you're kind of just holding your leg up doing exercises. It might be that you're laying on your side, lifting your leg out, laying on your back, lifting your leg out, things like that. So, and the reason for that is if you've got swelling inside the joint, if you have 25 mils of swelling, that is going to mean that your vastus medialis, which is your most inside quad, is going to be a bit inhibited, so not going to be working as well. If that's the case, you're then opening yourself up to so many more injuries at the knee. If you've got more swelling than that, eventually all of your quads, of which we've got 4, are going to become inhibited. And if you then go and run on that, the chances of you then rupturing your ACL, your MCL, anything else, goes up dramatically. So I don't let people wait there on it. The other reason as well is it breaks down your cartilage to have a lot of fluid within the knee joint itself, and we obviously don't want that for our patients either. So that'll be non-weight bearing initially until the swelling has gone down. And then if you've not got any swelling issues, we look at your range of motion. What's your range of motion like? We can kind of do this at the same time as well. So at the same time as trying to reduce the swelling, that is. So that's the next thing. Let's get your range of motion at your knee back. Can you flex? Can you extend? The next thing we want to do is looking at strength. What can we do to get this stronger? From looking at you, move from testing your strength, what's weak, what's strong, what do we need to work on? So that's how we go about it next. From there, if your strength has to be good, and we always strength test, so myself, Lucia, Nat, James, whoever you're seeing, we always strength test you at an appropriate stage. If your strength is where we need it to be, which is generally 85 to 90% of the opposite side, then we can look at doing some plyometric stuff. So plyometrics is going to be your jumping stuff. So you might just get you jumping on the spot to start with, might get you doing some hopping, some drop jumps. They're the kind of things that we look at. Again, once that's good, we retest on our plyometrics, on our jumping. We might get you to do a hop test, a triple hop test, whatever it is. So we do that next. And then we look at running. So we'll look at straight line running, then we start with change of direction, then sharper changes of direction, and responding to stimulus. So, just yourself running a zigzag line isn't the same as me shouting at you, run to the blue cone, run to the purple cone, run to the orange cone. So then we look at that. If that's all good, we can then slowly put in more and more sport specific stuff until you're back in training and you're back playing, or the gym, whatever it is that you want to do. So that's our process, but obviously it varies slightly on each person depending on their individual needs. So that's our main bulk of knee learning done. But I have had a few people that have already sent in questions. So now's the time. If you want to ask some questions, type them now and I'll see them in a second. And in the meantime, I'll go through the people's questions who have already sent me stuff, but they can't come to this live and they're going to watch the replay. So one of the questions was, hi Joni, I'm suffering from knee pain when I crouch down, mainly when trying to stand up again. I do not seem to have the power to jump, and if I'm on my feet all day, working on step ladders, for example, then we'll have a very dull ache. So for that kind of thing, obviously, medical disclaimer, I haven't assessed any of these people, so I don't actually know for sure what's going on, but I can just tell you the things that we would normally tend to look at. So if it's when you're crouching down or you're doing something repetitively, then we'd look at exactly what those movements are and what could be causing that. So if we're crouching down all day, we're keeping our knees in a really flexed position all day, so they're bent all day, or potentially might even be on your knees as well. So that's going to be added pressure, which a lot of people will cause soreness for them. So we'll look at ways that we can minimise the stuff that's aggravating them, and potentially if there's a weakness maybe in the quads, maybe they're not protecting the knee as much as they should, that's when we'll say, okay, we're going to try this strengthening exercise as well. So that's other things that we can look at for that kind of thing. The next question that we have is, hi Joni, I'm suffering from very bad knee pain in both knees. At times it gets very hot. I've had a lot of falls in the past. I'm so scared to go out for walks in case I have another fall. And this is really getting me down. So with that kind of thing, if they're getting quite hot, this can be indicative of some kind of arthritic condition potentially. If they're both getting hot and red and swollen, that's something we sometimes refer on to GPs for as well. But yeah, it sounds more like it's an arthritic thing. That is not the end of the world. We can reduce people's symptoms that have osteoarthritis by strengthening up the musculature nearby, depending on how bad it is. So that's probably something we'll look at. Also, if you've had a few falls and you're scared of falling, then we definitely need to be having a look at your balance. What is your balance like? If your balance isn't great, then obviously that can potentially cause issues for you as well. And balance and strength are related to each other too, although they're different. If our strength is low, often that's going to impact our balance. So that's the kind of things that we look at from treatment from that perspective. And just gradually increasing your confidence as well is really important. So the more people tend to do stuff with us and exercises with us, the more confident they get and the more they feel like they're able to do. So that's something we'll look at. And then another question we've got is, I recently developed knee pain on the medial side, that's the inside, around the MCL into the pes anserine. So the pes anserine is where our hamstrings and gracilis are attached into, and it's kind of on the front of our shin, just below our knee. And they've also noticed that they have a really tight feeling in their adductors when stretching, but it doesn't inhibit their flexibility, and they're asking if it could be a sign of a muscle imbalance. So that could be a sign of a muscle imbalance, definitely, so that's something that we would look at. The other thing it can be as well is if you're getting pain into that area, are your hamstrings maybe not working enough? Are your adductors overworking? Because our adductors, so the inside muscles on our thigh, do work in conjunction with our hamstrings. So if one's overworking for the other, then potentially that's going to cause pain. So that is definitely something that I would look at, just to kind of rule it in, rule it out. And just generally looking at how they're moving as well. So getting to do some exercises in the gym and saying, okay, yeah, I can see this, this and this. And then I got a message today as well from one of my patients that had meniscal pain, or meniscal tears. And they are actually a virtual patient of mine. They don't live anywhere near Croydon, so they can't come in face to face, but they were told at the time, this was last year, that they would need to have an operation to fix this and that they wouldn't be able to run. But we basically just did rehab, physio, they're back running, and he was in lots of pain initially, but now that's all cleared up and he's able to do what he wants. So just because you get a diagnosis and someone says, oh, you definitely need surgery for that, doesn't mean that you will. There are other options that you can try if you want to try and avoid that surgery route. And this patient was just saying how happy he was that he had gone down the physio route and he's been cleared by his consultant now. So yeah, that's a success story from knee injuries, which is great. If anyone else has got any more questions, now's your time to ask. And if you're suffering with knee pain at all, if you have any injuries, if you just comment below injury or knee pain, I'll make sure myself or one of the team gets back to you. Cool. Don't think we've got any more questions. Thank you very much for joining. Hopefully you found it helpful. If you want to send any other questions you might have, to maybe you don't want to ask in front of other people, you can DM me and we have a little chat about it. Well, thanks very much. Have a good evening. Bye.